Hello to everybody. This is Friday, means enjoy science. So thank you here for being with all the big MD Anderson family from MD Anderson, Houston, United States, and all over the world. Enjoy science. It's under the Chief Scientific Officer office, Giulio Draeta, and I have to thank all the time, of course, to the people who are doing the best part of the job, Ellison, Liz Kent, Laura Adame, Valerie Jimenez, and of course I have to thanks to you who are coming in hundreds to listen this wonderful series done by MD Anderson scientists and clinicians for you all over the world. Of course, today it's my pleasure to have here Dr. Nancy Perrier. I know Nancy for a long time. I learned from Nancy a lot of things because we're in the same committees, and all the time her voice and her comments teach me a lot. But I want to present here another Nancy Perrier who basically show why MD Anderson is #1 in the world. She's a surgeon, an oncology surgeon, and not only. Nancy Perrier finished at Rice Business School. So she's a woman who is doing surgery, but also understand very well the business. Congratulations. And of course, she is very well regarded. It's an endowed professor in our place, but also it's a director of the American Board of Surgery. And not only, if you will check on PubMed, you will see something that I prize a lot. Dr. Perrier is publishing a lot, very interesting clinical and research papers. And of course, keep in mind, it is a journal that not too many people talk about, but they are learning and they are citing about. CA Cancer Journal for Clinicians. This is in absolute the #1 journal in the world. Impact factor over 200 something, and Dr. Perrier, Nancy, is publishing a lot in the journal. With all this said, I don't want to steal the show. Thank you, Nancy, for being with us today. And we are very much interested in this disease, parathyroid disorders, because keep in mind, we can learn a lot in clinic and science, not only from the most frequent diseases, but also from rare cancers. This is a new topic of research in the next decade. Thank you, Nancy, and good luck. Thank you.
Good morning, and thank you, George, for the kind introduction, and what a wonderful series. Congratulations to everyone on the team for putting this together. Enjoying science. Again, my goal for the day is really to introduce to you ideas worth spreading with a common disease that really has a clinical aspect that leads us to understand and better predict cancer on a very interesting front. Parathyroid disease is one of my specialties. I am an endocrine surgeon here at MD Anderson, and the endocrine specialties are a unique combination of hormonally related orders that historically have been treated surgically. And we're going to talk about a disease today that constitutes a whole history of surgery at the realm of treating and recognizing from a translational standpoint that other ideas to enlighten and call to action are necessary when we put our great minds together. So with that, I would like to introduce the topic of multiple endocrine neoplasia type 1. This is an endocrine syndrome, and parathyroid disease is a part of that syndrome. And we are going to share in the next 30 to 40 minutes about why we care about this disease, which is historically a benign disease. George, I always like to start off with teaching and reminding sort of from where we've gone to where we've been to where we're going. And this is a quote from Stephen F. Austin, who was the first governor of Texas, where we are and where our roots are grounded. And Austin reminded us that one of the great pleasures a virtuous mind can receive in the world is the consciousness of having benefited others. And I think we do that. And I think we do that when we put our minds together and we take something that seemingly is unrelated and we really help other people. I'm going to begin this talk and the journey of multiple endocrine neoplasia by bringing to light this gentleman, Paul Vermer. Paul Vermer was an internist, a family practitioner in New York around the middle of this past century. And Paul Verma was an astute clinician, and he recognized in a family that he treated that there were a number of related individuals, and this was in 1954, that had that shared common diseases that were uncommon in his population of patients. He put together and recognized a syndrome called endocrine adenomatosis. And these were a series of endocrine tumors that appeared in this kindred at proportions that were grossly out of the expected realm of care. He recognized that this was an autosomal dominant gene. Clearly, it had to be familial with a high degree of penetrance. And you see here on the family tree that he created, this kindred for which his patient was the patient represented by number 9 here. And this was the father of 9 offspring, 4 of whom were affected by horrific peptic ulcer disease and also by hypercalcemia. The hypercalcemia came to be understood as related to benign tumors of the parathyroid gland. And you can see in following this the extension through the generations, and the pluses recognize those members of this family that died of this disease. In that journal of the American Journal of Medicine, Verma stated, "It is assumed that the syndrome in this family must be caused by a dominant autosomal gene with a high degree of penetrance," and that prompted further investigation. What Dr. Verma was really recognizing and what became clinically aware in that 1956 and beyond was the clinical syndrome of patients that develop multiple endocrine tumors. The majority of these patients initially present benign parathyroid tumors, and those are represented here. Again, the parathyroid glands are small glands in the neck that reside behind the thyroid parenchyma. They independently control the body's calcium metabolism. These patients also went on by age 50, 50% of them develop pancreatical or neuroendocrine tumors of the gut that turn out to be uniformly, as they metastasize, the true morbidity of the disease with a significant mortality. Also in this constellation of patients, pituitary tumors are recognized, 40% of them at these young ages, and most of them productive. So the astute clinician recognizing these 3 endocrine tumors could then recognize these syndromes and begin the process of predicting the other tumors. As time progressed over the quarter of the century, other tumors of the neuroendocrine cells in the thymus, in the lung, in the stomach, in the adrenal glands, and more recently described in the breast, have been associated and are part of this syndrome. In 1997, the gene was discovered, and it is an alteration in the protein MEN1. MEN1, as we know in the cancer world, affects many cancers, and the gene was discovered in 1997. The syndrome of these multiple endocrine tumors was labeled multiple endocrine neoplasia type 1. It was recognized that this is a tumor suppressor gene, and the loss of function is very site-specific. I'm going to draw your attention to the right of the slide because this was the cover of the Endocrine Society Journal in that year in 1997 when the gene was discovered. And this illustration was the illustration drawn by the surgeon who drew the clinical sequelae of the results of this loss of function of the tumor suppressor gene that encodes for MEN1, because these were recognized to represent cures that were demarked by surgical intervention. This first picture represents a subtotal parathyroidectomy, which includes removal of all but one small 30 milligram remnant of parathyroid tissue. It represents a pancreatectomy, at least a distal pancreatectomy, with the nucleation of tumors in the head of the pancreas because these are uniformly multiple. And also represents, again, the tumors that can be present in the lymph node system. Those tumors, the majority of these are functional. Some can be non-functional, but when functional, the endocrine metabolites and sequelae are the true morbidity of the disease. So the recognition that this is a surgical disease is the reason that for the last decade or two, we really have addressed this with surgical care. The important part of this syndrome is recognized by this historic graph that shows you the tumors in the parathyroid, the pancreas, and the pituitary and the thymus are the historic landmark most common diseases that occur with this MEN1 mutation. The parathyroid tumors almost uniformly in 90 to 95% of patients occur up to 10 years before the pancreas tumors arrive. The parathyroid tumors are benign, and the resulting metabolic sequelae is hypercalcemia. So the hypercalcemia can be distinguished on routine blood work. The operation to end the end organ effect is to perform a subtotal parathyroidectomy. But there's this window for most patients before the more malignant part of the syndromes manifest. So it's this time gap here which represents the true importance of what we can learn about parathyroid disease, particularly in the clinical era. So to remind those of you about the parathyroid gland, these glands have force, mass, and momentum despite their relative small size. These glands are about 30 milligrams in size, usually 3 to 4 millimeters in size in a normal position. When these glands become hypertrophied and at normal, they increase in cellularity, they increase in size, and an enlarged gland may be as large as a kernel of corn, it may be as large as a sunflower seed, but it's the identification of this enlargement, because the enlargement results in excess parathyroid hormone, which then turns off the feedback mechanism for negative feedback, and the patients resultantly become hypercalcemic. That's how they come to our clinic, because they're picked up by their primary care physicians for having the diagnosis, which is seemingly benign, called primary hyperparathyroidism. It's a primary problem in the hypercellularity of the parathyroid tissue. And in the MEN1 gene mutation and the genetic form of multiple endocrine neoplasia, it results from the autosomal dominant gene, so it's all 4 glands that are abnormal, and these patients present to our clinic with hypercalcemia. The early descriptions of this disease have been long known to cause bones, stones, moans, and groans that were classically reported in our medical school textbooks in decades gone by. Currently, in the current 20th century, 21st century, we see the bone disease presenting with osteoporosis. We see patients who present with nephrolithiasis, commonly known as kidney stones. We see decreased renal function on routine blood work. These patients may complain of constipation because of a slower GI tract motility problem from the high calcium. The patients may present with mild or sometimes even aggressive pancreatitis from the calcium sedimentation that can happen in the pancreatic organ. We commonly see cardiovascular disease because the hyperparathyroidism and the elevated PTH causes increased intimal thickness in the cardiovascular system, which affects the relaxation during diastole. So these patients are 4 times more likely than the general population to have cardiovascular disease, which is the most common cause of death. They also end up with reversible ventricular hypertrophy, and it's not uncommon that they are often referred to as being asymptomatic, which is a medical misnomer seemingly, because the neuropsychiatric symptoms are sometimes the most important and the least difficult to quantify. This is the constellation of depression. It might be fatigue. It might be difficulty concentrating, but it's the understanding that hypercalcemia, which is resulting from the elevated PTH, affects anterior cingulate gyrus, affects large muscle groups, affects cardiovascular system. In the sporadic population, we often see this in postmenopausal women. So this is a classic example of a postmenopausal woman who may have what looks like midlife fatigue, menopausal symptoms, and truly it's the beginning of hyperparathyroidism. But the onus is on us when we see these patients clinically to discern whether this is sporadic disease or whether this is truly part of a multiple endocrine neoplastic syndrome that's yet to be described in these patients. As a surgeon, the treatment of this disease is surgical removal of these enlarged glands. This is a depiction of an intraoperative picture. The patient's head is on the left of the screen under this blue drape. The patient's feet would be down towards the bottom right of the screen. This is a small midline incision in the neck. These are actually my 2 digital fingers retracting the thyroid parenchyma to the patient's midline. This is a right-sided incision. This is the recurrent laryngeal nerve. And these 2 small yellow appearing, peanut butter appearing glands are 2 small enlarged parathyroid glands causing this hyperparathyroidism, and in this patient, the beginning of multiple endocrine neoplasia. So the scientist in the room will remember that the parathyroid glands, albeit small, have a significant role in life because they make parathyroid hormone, which is a tightly regulated hormone with a very short half-life. The hormone is completely regulated by the calcium sensing receptors, which are present in multiple distant organs. PTH, which is short for parathyroid hormone, has an intense immediate feedback mechanism with calcitonin and vitamin D to help absorption through the gut and through the kidneys. A lot of these actions are through cytochrome P450 enzyme. PTH and calcium are vital to biologic processes. We know that if a patient has an operation that is not deemed technically successful and the patient has an over-treatment of this disorder, they can assume a state of chronic hypocalcemia, which requires chronic calcium supplementation, be symptomatic with tetany, cardiovascular collapse. We recognize clearly that PTH receptors are ubiquitous receptors through the cardiovascular, neurovascular system. And in fact, if you look through the medical literature, the number of papers that are written in articles just in any one year about parathyroid glands clearly and strictly outnumbers anything in size, volume of a matter of these very small glands that are very difficult to see. And the end organ effects of these, of parathyroid tissue is what brings us to understand the importance of these glands and what we can learn from them. In the MEN population, so those patients that have the mutation who present with parathyroid disease at a time frame that usually is at least 8 to 10 years before they develop a pancreatic neuroendocrine tumor, we see that in this constellation of patients, the majority of the symptoms that we're actually seeing that can be objectively measured are in the bones. We see frank osteoporosis most commonly in the distal radius. We see osteoporosis in the L-spine and also in the femoral neck. And this is a classic pattern that we remind our primary care physicians looking at postmenopausal women or looking at young men, looking at children, but individuals with bony fractures, recognizing that looking for bone mineral density patterns, then biochemically looking for hyperparathyroidism, which is based on blood work, then prompts us to look further for this disease. So why do we care? Which just goes back to our first slide. I've now told you about hyperparathyroidism, and why do we care about this at MD Anderson Cancer Center? We care because we understand that these small parathyroid tumors, majority of them go on to develop benign tumors, although there is a constellation of parathyroid carcinoma. But this tumorigenesis pattern helps us to learn so that we can predict and even prevent cancers and often pause the progression. If we learn more about this menin and we learn and we have this time frame, it's a unique opportunity that we often don't have with other malignancies. We know that there's a distinct clustering of genes that are altered in the profiles. We know that CDKN2B, CDKN2A, we know that the development that these alterations are important in the development of these parathyroid tumors, and that the hypermethylation appears to be important as well because it causes reduced gene expression. When we talk about seeing these patients in our clinic and wanting to learn about who has MEN1 and how we look for this, we know because of the familial component that the family history is often the very first thing that we're astute to, and we're in the clinical setting when we see these patients. If a patient has a family history of hyperparathyroidism, in other words, just in general asking, this is not a disease that patients will voluntarily write out on their review of systems in a normal dermatology clinic. It requires us to really be clinically inquisitive and to probe and to ask, anyone in the family have kidney stones? Anyone in the family ever have broken bones that were caused from something other than trauma? And digging into that family history. And again, if indeed the patient has a family member who also had hyperparathyroidism, there's about a 44% chance that indeed this patient has MEN1. They immediately go on a different track and we begin to screen them. We do genetic testing and then we screen them because we're looking for the more malignant aspect of the disease that we know historically is going to develop. When we talk and we look at predicting just from other common tumors, again, there's some data, and this slide was shared with me with my colleague, Carla Peterman, but looking at multiple endocrine neoplasia and other common endocrine tumors. Again, we know that looking at if a patient has primary hyperparathyroidism and recurs, that the odds ratio of them having MEN1 is more than significant. We know that if a patient also has a pituitary lesion, perhaps incidentally identified, but the risk of them having MEN1 is truly significant. So we use this in part of our clinical history, and probably the most important part of our prevention and epidemiologic aspect of what we do in our clinics here at MD Anderson in seeing patients who are at risk. So how do we make this diagnosis? We make it clinically, either when a patient has two of the three main endocrine tumors. So if a patient has a concomitant parathyroid, which almost always occurs first, which is the most common disease that we see, and then if they also are in our neurosurgery clinic somewhere in the upcoming years or have been with a pituitary tumor, or if there's a degree, for instance, of them having a peptic ulcer disease, it might be suggestive of a gastrin-producing tumor in the stomach, such as a gastrinoma. If a patient has a family history, we're going to see them in our clinic and screen them. And then we're going to do germline mutation testing looking for the MEN1 gene. And indeed, if we end up, when we do the testing, we're going to have the patients genetically counseled by our in-house in-depth endocrine genetic counselor. And we're going to perform testing on that index case. We're going to perform testing on the asymptomatic first degree relative of the patient or in any symptomatic family member or anyone suspicious for MEN1. And again, this is where we're going to use our prediction and prevention to use surveillance to look for these patients' disease before it actually occurs. And indeed, this is what we're doing when we know where to look for the MEN1 gene. Again, we know the gene is characterized by 10 exons. It centers around the locus of chromosome 11q13. The red bars here depict the microsatellites that are used in the polymorphic DNA markers to locate the regions. And we see those by the closed orange boxes. You can see the protein coding and the green boxes that are the non-coding regions represented by the yellow boxes. And so this is converted to mRNA, and then we do the translated regions to indicate untranslated regions as well. And we look for those blue bars, which are our nuclear localization signals. So we're looking for the gene. We recognize in the gene that there are multiple germline mutations throughout that whole coding region. We know that that there are, of these 1,100 mutations spread throughout the coding region, most are on exons 2 and exon 10. Many are inactivation mutations, and so we're looking for those, and we're also looking for the deletion of exons as well. And we're so this is specifically what our genetic testing component will look like. We also know that the landscape is that there is no real DNA change that occurs with high frequency. We see that there are multiple missense mutations, truncating mutations, frame shifts, and the library really shows here that there appears, when we look at these mutations, there appear to be the highest number, somewhere around codons 139 and 418. We see those clusters. So again, we're looking for that mutation, and again, commonly we're looking there. So how do we predict these tumors? Again, we have a patient, the parathyroid disease is the benign tumor where we are capturing them as we screen them. We treat them for that with surgery, and then we're looking to predict the parts of the disease that are now the more fatal and the malignant parts of the disease. And I bring to you this scenario because we know the part of this disease that's fatal are the pancreatic neuroendocrine tumors. And again, I bring to you the what ifs as we talk about, imagining and bringing our ideas together. What if we had known 10 years before Steve Jobs developed that pancreatic neuroendocrine tumor that he was going to develop that tumor? Because those are the what ifs that we know in this population. If we identify this disease early on, we have this window. And I invite you, how would the world be different? How would the world be different now if we had that what if, and had we done something, had we known, had we been able to predict? This is what a pancreatic neuroendocrine tumor looks like. You see this large tumor in the tail of this pancreas here. This is a cross-sectional CT. These are the patient's kidneys. On this right side is the liver. And if you look at where the yellow arrow is, that's a large pancreatic neuroendocrine tumor off of the inferior posterior aspect of the pancreas. Again, in this population of patients, we know with 70% certainty that this tumor is going to develop. What can we do about recognizing it, about pausing that progression to become this large, or actually can we do anything to prevent and to abate that MEN1 mutation from occurring and turning into this tumor in this pancreatic tissue? So this is a picture that shows you the pancreas. This is an intraoperative picture taken in the operating room, and this pink tissue here is normal pancreas, and you see this white firm tissue here. This is actually the tumor, and again, at this point in time, the treatment for this tumor is surgical. Since Wormer described this disease in the 50s, and then in 1997, the gene was identified, we still are at a point that this is a surgically treated predominant disease, and the understanding, and we've more recently brought in systemic therapies, but what can we do to predict and prevent? These are guidelines that were written, it seems like 2 decades ago now, and really they were the turn of the 2000 and then updated. But see, these are some of the screening and surveillance guidelines that we look for duodenal pancreatic neuroendocrine tumors in this syndrome. And you see here I have the acronym DPNETs to recognize that some of these are in the actual duodenum, the gastrinomas, and many are in the pancreas. But when we identify these patients and then the family members, we begin the screening, and you see here the screening pattern is really a clinical evaluation. We see them annually and we're looking for symptoms. We're asking about kidney stones. We're asking about depression. We're asking about broken bones. We're asking about diarrhea. We're asking about change in bowel habits. Again, understanding from the pancreas standpoint of what some of the functional tumors may be. And then we're also beginning at an age of screening, usually at about age 20, of doing cross-sectional imaging. So we're going to do a cross-sectional CT scan or an MRI or an endoscopic ultrasound, because we're looking for those small pancreatic neuroendocrine tumors so that we can know about them and develop a plan. And then we're going to follow them again. And the goal is we're looking for a change and pace of tumor progression. What we're looking for when we're looking at these tumors, and what we really scientifically need to understand, are which ones are putting these patients' lives at risk. Which ones are small tumors that are going to be slow and non-aggressive, and the patients can live harmoniously with those tumors for 10 or 20 years before they come to a pancreas resection, and which tumors do we need to act on at a very rapid and aggressive rate, because we're looking at a tumor doubling time and we're looking at the metastatic potential. So currently we're looking at who is at risk, and our parameters at this point are those that need quantification and need improvement. We currently look at tumor diameter. We know from retrospective cohorts, both here and around the world, that the increase in size of a tumor certainly correlates well with its degree of aggressiveness from metastases. So if we have a young patient with a tumor that's 1 centimeter, we'll often follow these clinically with an endoscopic ultrasound in a year or two, because we're going to be less concerned. But when we see that tumor come to a 2 centimeter, 2.5 centimeter mark, we're going to be concerned about the role that we now need to surgically intervene. We also, in the more current genre, have been looking at the genotype-phenotype correlation. Again, which mutations seem to correlate with more aggressive PNETs. Some of our own work from here at Anderson with our large cohort of our MEN population of more than 300 and 400 patients and kindreds suggests that those with an exon 2 mutation look like they are mutations that should be screened more closely. We know from Barch and others that the CHES1 interacting domain is also one that's worrisome, and WNJUN-D is also the interacting domain. There's certain polymorphisms that are suggestive. We have data that suggests that perhaps estrogen exposure can be somewhat protective. So understanding that in this population that we want to use prediction and prevention needs further exploration. We know that males tend to have faster progression of the neuroendocrine tumors that develop in the lungs. So data that we have, but again, putting all of this together into rational and concrete clinical guidelines requires science being brought together at a translational level. This is information, again, that's a little more contemporary and current from the Dana-Farber and from the Dutch group, again, looking at liver metastases. We know that the liver metastatic disease is the part of the disease that then becomes the role of systemic therapy, and the true poor prognostic indicator is indeed, you see here by the graphs, you see that almost exclusively those tumors with ARX and PDX1 negative, those are the tumors that seem to have the worst prognosis. And what we know is this is true of PNETs and neuroendocrine tumors independent of the MEN1 germline mutation status. So again, a lot to learn about this disease and a lot for us to be able to then bring on to other diseases with MEN1 and other diseases similar. And this slide really is the depiction, just backing and showing you that it's the survival demarked here by the yellow graph shows the 10-year survival is at 50% for these patients that develop liver metastases. So understand that initial presentation might be in the most common age of presentation of the syndrome is the parathyroid disease in the 20s and 30s. And then about 10 years later, so patients in their 40s with PNETs. And then again, so we're talking about a young cohort of patients here, and we're talking about true decreases in survival. So how are we going to pause the progression or prevent this advanced disease? What interventions do we have? And I bring you these discussions as a surgeon because currently surgery is our modality. But as we look at the aspect in the presentation of this disease, I bring you to look at the bottom of the slide and remember this is a sequelae over time. The parathyroid disease is managed often up to a decade before the pancreas disease. The parathyroid disease is almost always the entree for us to suspect the syndrome, to do the genetic testing, to garner the diagnosis, to begin the surveillance for the PNET syndromes. And so from that, how do we find those? How do we early detect, and how do we find ways to better manage and avoid those with advanced stages? And our interventions currently are reductive surgical interventions. There's new technology on the horizon for radio frequency ablation. We have our own UT colleagues using endoscopic ultrasounds with cryoablative techniques for small tumors. So understanding in this patient population the possibility of identifying tumors that are less than a centimeter on good cross-sectional imaging and actually ablating them or using that as a biopsy and then finding tissue to find other analogs. We know that somatostatin analogs are currently available and we use them. We also use systemic therapies for advanced disease. Our medical oncology GI colleagues will often see these patients that missed the earlier presentation, either it wasn't picked up by the primary care physician, and they present with advanced disease that need mTOR inhibitors and VEGF inhibitors and other forms of systemic therapy. So as a surgeon, just going over some of the surgical, this is an example of a probe of the endoscopic ultrasound probe that really is a 22 gauge needle, and it's a cool prototype. And this slide was shared with me by Dr. Thasani, Nirav Dasani at UT Health, and he and our colleagues here, again, looking at some of the early outcomes of ablating these small tumors, using this probe to prevent progression. We don't have long-term outcomes. We don't know the mortality of this, but we are thinking, and the mindset is that earlier intervention might prevent the downstream sequelae that occurs when we need to do actual pancreatectomies, either of the head of the pancreas or the tail. We also have exciting results coming that are available when we talk about peptide receptor radionuclide therapy. Again, we know that dotatate results, and these tumors, these neuroendocrine tumors, show overexpression of somatostatin receptor to these ligands, and we're looking at going beyond octreotide conjugates for what we use for diagnostic purposes when we're looking for the disease and we're looking for metastatic disease, but looking at other therapies that can have a durable, effective therapeutic treatment with drugs like lutetium. And we have seen some symptomatic responses and some partial biochemical responses. Remember, these pancreatic tumors are often functional, so we can look at the functional components. And this PRRT, again, it's cytotoxic alpha emitters. Been available in Europe for 2 or 3 years, now available as of last year in the US. But again, exciting, looking at some of this therapy for tumors, but again, realizing that this really needs to be, we need to address this from all fronts. And again, here is really just an example of the antibody being attached to a conjugate with the drug, and the drug is really the cytotoxic payload. As we understand menin, and as we better understand menin and its cell cycle, For instance, the way that menin in the cell cycle intercedes for parathyroid tissue is not the same that it is for pancreas tissue and others. So as we learn about this, so menin in parathyroid glands, it's really at the MLL complex that it mediates the methylation of the histones that you see here, and it interacts with the transcription of chromatin. And then when menin is mutated, it becomes unable to suppress that transcription factor, and it predisposes to the tumor formation. And that tumor formation in parathyroid glands is that overgrowth, but it's a benign tumor formation. And we also know that there's a role of we know that there's a role of P27 and other things to learn from parathyroid tissue. We also, when we look at things in PNETs, we know that cyclin-dependent kinases are really important in altering the cell cycle, and we know that it's here. CDK4 and 6, and again, if we can have drugs and we look at drug development in this realm, this is going to be important as we, again, these patients that we know are going to develop PNETs, and then we know when these PNETs are small to prevent them from progressing. We also know that alterations in P16 suggest cell cycle dysregulation, and we know that the loss of P18 is really common in the development of PNET. So again, really understanding this from other tumors and understanding it to put it in effect in this unique, rare endocrine tumor model, and looking for CDK inhibiting compounds that really will affect this cell cycle progression. I've listed some references here for you who are interested in, again, good work, and reminding us that the diverse function and interactions of protein occur both at the nucleus level and in the cytoplasm. Menin has multiple, affects multiple proteins. So again, understanding it, and then really understanding that its role in interacting with other proteins, and for us from the clinical standpoint, how those affect the aggressiveness of these tumors, to give us ideas on which domains are patients for whom we need to pay closer attention. And again, these are the groups that we think are more likely to have PNET development and what's important about them. And importantly, can we segregate and find the grouping that are more likely to die from PNET death? So these are the exciting things that we're trying to explore. And a great example of Anderson, so through the translational collaboration and the liquid biopsy study, this is a unique opportunity, and again, a rare disease. The endocrine hormonal system in and of itself is complex, and the rarity of this tumor, and this is a coalition and a collaboration that we brought together. Carla Peterman is one of our colleagues and one of our from the Utrecht group in the Netherlands, which has a large population. As we join with the NIH and as we join with what we're doing here at Anderson, we're looking at longitudinal data collection and studies of plasma and plasma-derived exomes and tissues, and we're collecting this longitudinally on all of these patients, beginning with the initial presentation of the benign disease when we see them as they present with parathyroid disease before they go on to develop the other tumor end organ effects. We're looking to identify those actionable signatures in the progression using integrated multi-omic profiling. And we're also looking at retrospective blood samples from these patients. Again, trying to put this all together from a smaller cohort and then an international collaboration, because we recognize the importance of from the parathyroid off to the PNET, off to neuroendocrine tumors. This really is a priority area because it allows us, it's a unique disease and it requires unique strategies so that we can better understand how to predict and prevent. We're looking for that observation of who has metastatic potential. what chemo prevention trials can we initiate, and what therapeutic targets can we biologically define some plausible mechanisms. Again, both in can we better understand? Can we better understand when these tumors are small and 1 centimeter? What receptors are on them, and can we get to a point where we can really change the pace of this disease? And again, working with through the translational research here, both with our collaborators and our group, that really this is an all-force effort of really showing that we have a unique opportunity, and the representation of this disease coming from a clinical standpoint of a benign tumor in a patient that has a unique window before the malignancy develops gives us a unique epidemiologic responsibility before metastases occur and before even the tumors occur. And our current toolbox of looking at surveillance with radiographic studies and with biochemical assays that really only predict after the disease is advanced, and then with Rose surgical resections, we really need to increase our knowledge to understand menin, its role in the tumorigenesis and other cancers, to really meet this unmet clinical need. And we hope that this just excites you about as we enjoy science, but biomarker risk assessment, prevention, alternative therapies. We hope that this disease becomes non-surgical in the next generation. And I leave you with the consideration that I hope we have inspired you to recognize that all these ideas are worth sharing. Imagine had we known, imagine had Steve Jobs known in 2000 what was going to happen in 2011. Imagine how things might have been different. So I'm going to leave you with this. This is one of my favorite slides. I'm a Mayoite by heart, and what the Mayo brothers represented, again, by bringing together concentrated people with similar interests and reminding us, as I know George Kalin is such a great role model and mentor, and I know that because I hear it from everyone that works around him and with him and with all of us. Remember, the old and the young, both those physical and mentally young and thought, we should travel together. The old to point out the pitfalls to which they have fallen, and the young to devise ways to avoid them. And really, I hope we all can remember and learn from that. And I'm going to end by just dedicating this. This is Mark Lewis, who's just a phenomenal physician. He was a physician here at MD Anderson. He currently practices on the West Coast. And Mark has taught us both as a patient, as a physician, as a father, that truth is in healing really occurs in many ways that defy quantification. And it's the art of medicine. It's the art of us taking care of these patients, of listening to them, of going back to Dr. Vermeer in 1954 when he was actually caring for these patients and paying attention. The subtleties of recognizing that a family member had peptic ulcer disease and so did another family member really requires paying attention to what we do in the clinic, and then taking that scientific curiosity and bringing it forward and moving it into the lab. And really, that is what we cannot quantify, and that is what we do together. And we do it well because together we are better. I want to acknowledge that everything that we've done here and talked about with our collaboration, I want to thank Carla, who is really a person that lives, much like Mark Lewis, lives and dies by the day of really helping these patients with all that she has, and really is critical to bringing these projects together. The Hanash Lab and Jonas Farman in that lab, and Amanda, who works in the animal portion of this with Gigi's lab, and Dan Halpern in the GI Medical Oncology Group, and Stephen Wagasbeck and all the medical endocrinologists, and of course my own partners who help take care of these patients and cover and are as interested, curious, intellectually with this disease as I am. And then our partners around the world, again, whether it's the NIH or UTRICH or the group in New Zealand, and that has a concentrated effort of concentrated prototype of these patients, but it really requires us to all come together in these rare diseases to make a difference. George, I really thank you for the opportunity to share my enthusiasm for this disease. I hope you've learned a little bit about parathyroid glands and why they are important, and I would be happy to answer any questions. Thank you.
Thank you very much, Nancy. This was a wonderful presentation. You can be sure that now all of us will start to move on parathyroid disease and neuroendocrine diseases. And in fact, I wanted to ask some questions. It was a wonderful presentation because it covered everything from molecular to hereditary to clinical and of course to therapeutics, because this is what counts the most for the patients. And there are already some very interesting questions. The first one, could you please elaborate more on reversible left ventricular hyperproliferation in primary hyperparathyroidism? Does it mean it is a transient phenotype?
Thank you for that question. So we understand from the Karolinska group that has a wealth of knowledge of following these patients in a closed contact setting. And we know that the hyperparathyroidism, so the hypercalcemia in and of itself, in addition to the prolonged increased PTH. So the normal PTH has an onset that's much like melatonin, where it peaks in the evenings and in the middle of the night and then relaxes during the day. But in a hypercellular parathyroid gland that's put on, for instance, by this MEN gene, these patients end up with consistent chronic elevation in PTH, and that they lose that diurnal rhythm. And in that, they lose the relaxation of diastolic during the diastolic phase. So they end up with diastolic type hypertension. And it does seem reversible when we correct the hyperparathyroidism over time. So the cardiovascular disease puts them at an increased risk for all cardiovascular death and all cardiovascular deaths. And most commonly that's MI and stroke, but the intima-medial thickness increase, the hypertrophy of the ventricle. We see this more commonly, and we see it in HPT, but we do see in some patients a resolution over time after the disease is cured.
Thank you. Thank you. Another question. Are there any known dietary modulators which can be utilized in that 10-15 years time window?
Are there any
dietary modulators? So some dietary components that can be used in the 10-15 years window.
Sure. We would love to know. We currently, there are none that we're frankly aware of that have been proven. The idea, for instance, of estrogen, could we modulate, would we expose patients at an earlier age and for a longer time to estrogen because of a protective effect? Some of the data seems to suggest perhaps so, but we don't have enough information to know that there's any particular dietary modification that will that helps. Even in just the hyperparathyroid disease, again, it's not just dietary. Patients will often ask us, oh, if I stop eating calcium, will that make my disease less likely to recur or come back? It's not, because the calcium is simply a side effect of the excess PTH. And the excess PTH is an effect of, of the gene mutation, the hypertrophy. So for those of you who understand modulators, this disease is looking for you. We need you, because right now we do not.
Thank you. Now, one question from the point of view of research, so science. So there are these neuroendocrine tumors with a hereditary component, but there are well-known tumors on GI tract, let's say neuroendocrine differentiation of colon cancers, who are really doing very badly, very ugly in patients. Now, here at MD Anderson, it is an interest in expanding this concept of the study of neuroendocrine tumors of different location and different origins, knowing that they associate with more metastatic disease and so on.
Yes. So, so this project, and we're concentrating on this particular mutation, but certainly the thymic, the GI, the rectal, the carcinoid, certainly there is a lot of work. There's a lot of work being done in GI medical oncology, as you said. For instance, in the somatostatin receptors and the like. The uniqueness of this syndrome, however, George, is that in 95 to 98% of the patients, the initial presentation is benign, and we don't have that in the GI tract and in the thoracic tract, right? We end up identifying when those tumors occur, we make the diagnosis. So yes, the management from that point on, we can then use in the same population that has aggressive liver disease from this disease. But our emphasis at this time is what is it that we can do because before the disease develops earlier on. But certainly, certainly what we learn from the other neuroendocrine systems for what makes these cells respond, we certainly, can we start applying that in a neoadjuvant setting, even in a preventive setting? That would be the great option, because I have the 20 and the 30-year-old in my clinic that don't yet have disease, right? Is there a pill for that, or prevention? Yeah, to answer your question along about way, yes. I think that work of Dan Halper and James Yao, that medical oncology group, is really working on that side of it.
Thank you very much. So I would say thank you for the wonderful talk. In fact, we already got feedback, fabulous talk. Several people and all of us like it very much. Several already expressed it in the chat. Thank you, all of you. And thank you for this wonderful presentation. It covers exactly what is very important for patient, wonderful therapy, and of course, genetics who can help to focus on the patient. And with this said, thank you, all of you who attended. Thank you, Dr. Perrier, for your wonderful presentation. And we are waiting for you next week with another very interesting presentation on a very interesting topics. I let you to be curious till next Friday. And with this, keep in mind the last sentence that I tell it for some times now: science, it's unifying. Science is putting the people together. Doesn't matter the countries, doesn't matter the color of skin, because what we love more in science and in clinic, we love to make discoveries and to take care of our patients. And in fact, today's presentation was a wonderful clinical research presentation showing what MD Anderson is not to do the best. Take care of patients. With this, thank you. Thank you again, Nancy. Thank you to everybody, and see you next Friday.
Thank you, George. Happy Friday, everybody.